Today we're talking about the Gracey 1314 curette. We have Bryn as the clinician, Mary as the patient, and Lauren as our videographer. First, we need to establish our barriers and PPE. For our clinician, this means glasses, mask, lab jacket buttoned all the way up, hairpinned back, and gloves. We have set up appropriate barriers on our chairs, our unit, and our light. Notice the patient also has on safety glasses and a patient bib. The patient is lowered to supine position. The clinician is seated properly in an upright position. Her feet are flat on the floor. The clinician double checks that her elbow is in line with the patient's nose. Since the clinician is working on the lower right posterior sextant, or sextant 6, she will position her light directly above the oral cavity and will be in the 9 o'clock position. Our clinician will begin by grasping the Gracey 1314 with a light, modified pin grasp, while maintaining a soft C shape with thumb and index finger directly across from each other. The Gracey 1314 is an area-specific curette with a rounded toe used for subgingival instrumentation in the posterior sextants of the mouth. Because it is a Gracey curette, it is considered self-angulated, meaning the cutting edge is at the proper angulation for instrumentation when held parallel or at 90 degrees to the long axis of the tooth. The cutting edge, which is the lower edge of the instrument, is at 70 to 80 degrees, which is ideal for proper removal of calculus. Our clinician will now evaluate the instrument to determine the correct working end. When the terminal shank is parallel to the distal surface of the tooth and the handle is coming up and out of the mouth, you have established the correct working end. For clarification, our clinician will demonstrate the incorrect working end. Notice how the instrument wraps around the tooth. This is considered incorrect. With the correct working end, the clinician inserts the instrument at 0 degrees and then opens up to 90 degrees. She establishes the correct fulcrum 2 to 3 teeth away from the tooth being worked on so that she is out of the line of fire. The clinician is maintaining an upright fulcrum to ensure the efficient lateral forces needed for proper removal of light to moderate calculus deposits. The clinician begins at the distal line angle with an exploratory stroke. This includes short, controlled, overlapping oblique strokes, making her way towards the distal surface of the posterior tooth. The clinician is then able to use a vertical stroke on the distal surfaces. If calculus is detected, the clinician will engage a working stroke with lateral pressure for the removal of the deposit. Notice that the clinician is using the toe third of the instrument and using a rocking wrist motion in order to maintain neutral wrist movements. She uses her mirror to retract the cheek in order to see the distal surfaces of the teeth. The lingual surfaces have the exact same technique as the buccal surfaces, except the mirror will now be used to retract the tongue and provide indirect vision and illumination. After the clinician feels that the calculus is removed, she uses her 11-12 Explorer to assess the areas for remaining calculus.